Dementia mainly affects older adults, and whether we like it or not, we tend to treat older adults as a population that doesn't deserve the kind of coordination or care because they're at that latter stage of the life course.
A dementia diagnosis can take years, and even after receiving one, many families are left wondering what to do next. Dr. Saskia Sivananthan is the CEO of the Brainwell Institute. She was in Calgary at an Alzheimer's event advocating for a better way forward. She says people living with dementia and their caregivers are often forced to navigate a fragmented system. Drawing parallels to cancer and stroke care, she challenges the stigma surrounding dementia, emphasizing that a diagnosis is not the end of hope.
I was actually at a dinner and speaking to my to a dinner companion about the work that I do in dementia, and she's a nurse. And I said, what we want to get to is the type of hope and system coordination for dementia that we have for cancer and stroke. And she stopped me and she said, "Oh, you can't talk about cancer in the same sentence as dementia." And I said, "Why?" And she said, "Cancer has so many treatment options. A lot of them can be slowed or can be reversed or eliminated, and we just don't have that for dementia. So you shouldn't put them in the same sentence." And that really like ignited a fire in me because I went back and looked at the history of cancer, and cancer had the same sort of stigma and issues and lack of coordination, lack of access to treatments, because those early treatments for cancer were sort of like where we are right now for Alzheimer's.
Sabanathan says with the right supports, people can continue to live meaningful and engaged lives in their communities. Watch our conversation about why dementia needs a system that helps people access support from diagnosis through every stage of their journey.
Really, what it means for me, we work directly with people living with dementia and care partners as well. We don't deliver programming, but what we do is support them in knowing where to navigate through the health system and giving them a voice for their stories as part of advocacy. And one of the things I hear time and time and time again, especially from caregivers, is first, I didn't even know how to get that diagnosis. It took so long, sometimes a year, 9 months from the first point before you even get the follow up appointment. And during that time, they're kind of left to figure things out for themselves. And then once they get that diagnosis, often they're said, well, go access community resources or home support resources. But what does that mean? Where do I go? And eventually, it's the care partner, the caregiver who has to figure out what those support services are. And then they might find out that there's not enough of it. And then where else do they go? This is the fragmentation of our system. We don't have a pathway through the system so that a person knows where to go next, how to access supports, what to expect, and that there is someone who helps them navigate that. And the example I used previously in the talk, but that I use frequently, is cancer and stroke are these other very complex, large conditions. But if you were to be diagnosed with any of those conditions, generally there's a pathway through the system. And so it's not the person who has to figure out the pathway. The health system is already set up so that you move along through that pathway all the way from diagnosis to end of life. It's not perfect, but it is much better than what we do for dementia. So the analogy going back to air traffic controllers is sort of like if you think about dementia, and let's say you're traveling by airplane and you're going from Toronto to London. Well, there is some kind of a route to go from Toronto to London, and then there are planes that will take you there. Think of the planes as the dementia programs that will fly from Toronto to London. Now think about traveling, but not having any air traffic controllers as you're trying to get from Toronto to London. That's what we do with dementia. We have no air traffic controllers. So people are really left to figure out for themselves, is this plane going to crash mid-flight? Is this even the right route? There's a pileup on the runway here. What do I do? Where do I go next? At a systems level, we just don't have eyes and accountability or coordination. And so it's the caregivers who become the air traffic controllers, in addition to the caregiving that they're already providing. And this is what we're hoping to really establish, is to support provinces to really think about air traffic controllers for dementia. What is that accountability? what would care coordination look like so that it's not the families and the people living with dementia who are figuring that out. It's the province that supports them along that journey.
Is it fair to say there's adequate programs, like the planes are okay, but it's just the coordination of the programs?
Well, we think planes are okay. There are certainly a lot of programs, and the provinces, especially Alberta, has invested in many different programs for dementia. But we don't actually know for sure because no one knows what all of those programs are. We don't know if they're being duplicated, and often they probably are. There's duplications of services. We also don't know where the gaps are, whether a program might be doing a good job in one area, but there's a gap between, going, for example, from your family doctor to home care. We don't know what that gap is, or community resourcing and mental health. And that's part of the point around care coordination. We don't even know if we have the right programs and if those programs are delivering what we hope they're delivering for people living with dementia.
It sounds like you're taking a step in the right direction with this task force that's been started in Ontario. Can you tell our audience a little bit about that?
Sure. So, Ontario, just like Alberta, is a complex province, and we have many different people who will be living with dementia. And for every person, there's at least one care partner, if not many more. And the same kind of fragmentation we mentioned that I mentioned earlier in Ontario is being seen, where people just don't know where to get the diagnosis, what to do next. They also don't know about things like rehabilitative care that can be supportive earlier during that journey. They don't know how to access treatments. We've been hearing a lot about new blood-based biomarkers around these new classes of therapies and treatments that are coming out for Alzheimer's disease. People want to know how to access them, if they're even eligible, and there's no system in place to be able to do that. So what the Brainwell Institute did is worked with local partners. The Alzheimer's Society of Ontario is the partner that is helping host this task force, and it's funded by the Weston Family Foundation to be able to bring all the partners who deliver any form of dementia care in Ontario. So that includes acute care hospitals, it includes medical associations like the College of Family Physicians, nursing, social work, rehabilitation, home community care, housing, transportation eventually will also need to be included so that together we can talk about what does care coordination look like and what's the roadmap to get to that outcome where people have a pathway through the health system. There is accountability and integration at the provincial level to be able to achieve that. In Ontario, there's a bill called Bill 121, which is the Dementia Care Bill. And part of the requirement for the minister is to develop a dementia framework and to implement that framework. Implementation of that could include this integration and accountability, some form of dementia infrastructure that is responsible for coordinating care, basically the air traffic controllers. And if we think about the Alberta context, with the health system redesign that is occurring and the four agencies, Alberta is one of the few provinces that has a primary care agency as well as acute care, assisted living, and then mental health and recovery. Well, dementia touches all four of those agencies, right? You would either enter from one of those agencies or need to access them at some point in time. So, how do we think about integration and coordination in the context of this system design? The system redesign. It's a real opportunity to think about coordination as that system is being rebuilt.
And so when do you foresee having the results from this Ontario task force to help assist us across the province or across the country?
Well, the recommendations for that roadmap will be coming out in the next few months. We're actually hoping for the preliminary recommendations to be developed by the fall. And the province is also engaging in public consultations right now in Ontario. So that's going to go kind of hand in hand with supporting those consultations. And I think similarly, if we're thinking about Alberta, we'd be looking at engaging and building partnerships and stakeholders collectively to be able to think about what would an Alberta task force look like if there is one, and how to engage with government so that it's in collaboration and co-design. You would never want to do something completely in isolation, because ultimately this is about how government, how the province takes accountability for that coordination.
Does it make it more challenging to coordinate dementia care efforts when it's in those four silos that you said dementia touches all of the things that used to be AHS? Or what's your thoughts on that?
Well, I think dementia never travels alone, right? And so, even in a centralized, more centralized approach like Ontario Health, which is what Ontario has, dementia is still not coordinated. It's still a fragmented condition. And that is also only the clinical side or the medical side of things, right? We're not considering the fact that with dementia, it's really about the community based care. It's about housing options, it's about transportation, it's about caregiving supports, which really sit outside of the health system. So that coordination needs to recognize and integrate with that as well. This is where we do draw inspiration from conditions like cancer, which recognizes the medical clinical pathway and has set that up, but really supports navigation and integrates with community based organizations as well. And we need to look at the same. For example, mental health is another condition that does that, that straddles beyond just medical
Mm.
or clinical. So learning what those levers are and then leveraging those for dementia will become really important.
Why is it that we have this apparent lack of coordination when it comes to dementia?
Stigma is a huge driving force.
Mm.
Dementia mainly affects older adults, and whether we like it or not, we tend to treat older adults as a population that doesn't deserve the kind of coordination or care because they're at that latter stage of the life course. I also think dementia is often associated with mental health. There's a lot of stigma around that condition. Um, and then I think the third piece is that when we think about dementia, we tie it to identity. You know, a person is their memories in many ways. And it is a very difficult thing to come to terms with someone who may not have the same memories or the same person that we have associated them with throughout their earlier life. And that takes a lot of training. It takes a lot of supports to recognize the person is still there. The Still Me campaign, I think, is really beautiful because it recognizes that the person is still the person. They're in there, and it's a matter of how we engage and connect with them and how we are present with them. And that's very challenging with dementia. So I think all of those pieces contribute to why we've just not tackled dementia. And we tend to think about dementia and silo it as long term care only, sort of, oh, let's get to that end stage. But this is an active process. It is active aging. And so, how do we work to be able to support that coordination means that we can also go even further upstream at the risk reduction and the screening and prevention side of things so that people are supported all the way through.
Yeah, you'd mentioned the stigma, and I was looking more into that, and I had heard that people actually put off getting a diagnosis or going to face it because of stigma. Is that correct?
Absolutely. Yes. We've often heard that folks might see some of those earlier flags and put it off, sometimes because of stigma, because they're scared. Dementia is the number one condition that people are afraid of developing. They're afraid of developing Alzheimer's disease, the most common form of dementia. And a lot of it also is the lack of hope. We don't do a good job of helping people feel hopeful or supported. And so, in the face of that, again, people are often putting off the diagnosis. And I would say the flip side to that, as well as healthcare professionals themselves, family physicians and healthcare professionals who also have stigma, who might not feel that they can do very much to support the person. And so, even if they recognize that they have cognitive impairment or some form of memory loss, they won't necessarily provide the diagnosis until they absolutely have to. On average, it's taking 2 years to get that diagnosis. And I mentioned this as, at the talk, which is I was actually at a dinner and speaking to my to a dinner companion about the work that I do in dementia, and she's a nurse. And I said, what we want to get to is the type of hope and system coordination for dementia that we have for cancer and stroke. And she stopped me and she said, "Oh, you can't talk about cancer in the same sentence as dementia." And I said, "Why?" And she said, "Cancer has so many treatment options. A lot of them can be slowed or can be reversed or eliminated, and we just don't have that for dementia. So you shouldn't put them in the same sentence." And that really like ignited a fire in me because I went back and looked at the history of cancer, and cancer had the same sort of stigma and issues and lack of coordination, lack of access to treatments, because those early treatments for cancer were sort of like where we are right now for Alzheimer's disease. They're not great. There's a lot of side effects, but it takes refinement, it takes time to get to the point of better treatment options and investments in those treatments and research. And cancer very much was in the same point. Physicians didn't want to give a diagnosis of cancer. People didn't want to even say this. They called it the C word. They didn't even want to talk about it. And that is the same kind of stigma. There are a lot of parallels to what we're facing with dementia right now.
Wow, that really hits hard when you make that comparison, and then that kind of thinking is still out there.
Change that mindset, but also I often tell people recognize that yes, dementia is a difficult condition. I don't think there's any pretending around that. And it can be long, it can be sometimes 8 to 10 years. And yes, eventually at that end stage, the person is unable to recognize their loved ones and take care of themselves. But there is still hope even then. There's ways to have good quality of life, to still be engaged in your community. Rehabilitation and treatment options are still very relevant, even through those earlier and moderate stages. And just like any condition, I think the more we talk about it, the more we share these stories, the more we're not alone. And then the more awareness we have so that we can continue to invest in the systems for more of those options.
You had mentioned that some people are purposely putting off confronting perhaps a diagnosis, but are there other reasons why it's taking so long for people to get officially diagnosed?
Yes, some of the reasons have to also do with healthcare professionals being trained, adequately trained to diagnose and support people living with dementia. In our Mind the Gap report, when we looked at the data and nationally, only about 41% of family physicians said that they felt they were adequately trained to diagnose and treat dementia. And the reason family physicians are so important is they're the entryway, right, into most health systems, particularly for dementia. And if they don't feel adequately trained, then how are they going to support the person throughout? And then, of course, they don't have a system. They don't have the pathway to be able to know what those next steps are, to be able to make the referrals and know that there is a team that can support them. And that was part of the reason that we launched the Braid Hub. Part that work is funded by the Government of Canada, CIHR, the Institute of Aging, and it's a partnership with research universities, McMaster, University of McGill, and the University of Calgary. And it's working with family physicians and community partners to be able to understand where those gaps are. How do we support family physicians to be better trained to access resources, as well as to recognize that there's a diversity in Canadians and that means culturally sensitive training and supports will be just as important. And that's part of the work of the Braid Hub.
Are MRIs part of the reason why people aren't getting diagnosed? Like the screening, do you need that kind of screening to get a diagnosis?
Well, right now, the main form of getting a diagnosis is through what's called a cognitive test. So it's either a MOCA or an MMSC, where your family physician will walk you through a series of questions, and then based on that score, they will, assess if there's cognitive impairment. They will also do some exclusionary blood work. Sometimes they will do imaging. You're right. Um, and access to getting that MRI or CT scan or even PET scan is extremely limited based on our current infrastructure. I think also, though, it's access to better diagnostics. A cognitive test, a screening test, is very difficult to administer. It's not necessarily subjective, but it can be influenced by the context of the patient. So sometimes, if the patient has other cultural contexts, they might not recognize some of the questions that are being asked. Some patients, especially women, are more verbally fluent and linguistically better. And so they might pass the cognitive screen, even though they're having difficulties in other areas. And so this is why, and then I think the other piece is, as a family physician, you have to do this test and then deliver a diagnosis without being able to have something more tangible to support why it is that diagnosis. And so things like blood-based biomarkers, screening tools that might include retinal scans, and then imaging to support that diagnosis is a much more holistic way to be able to also support the family physician. And we are lacking those. We also, again, because of the lack of a pathway and the lack of coordination, we can't scale access to those therapies or to those screening tools or cognitive tools without being able to be able to innovate and scale. We don't have the pathways to support that.
That's a lot on the plate of a family doctor.
It is absolutely. It is again the reason why it shouldn't just be a family doctor who's providing that care. They should be supported by an interdisciplinary team, and they should have the pathways and resources to be able to refer on, to have navigators who might be able to help coordinate what that care looks like. We talked about this at the talk. For example, there are diabetes navigators or diabetes educators, so that it's not the family doctor who has to support a person with diabetes. They can make that preliminary diagnosis, but then know that a diabetes educator will help that person understand the lifestyle factors, what the referrals are, and how to navigate the health system. The same thing goes for stroke and for cancer. There are care navigators who get engaged early. There are interdisciplinary teams, a social worker, an oncologist, other referral partners. It's not all on the family physician to provide the care because that is an impossibility and it's unfair to them.
And just to clarify with the diagnosis, you can be officially diagnosed just through that cognitive test?
No, so you should be diagnosed through a range of testing. They will often do exclusions of,
Hmm.
they'll do blood work to exclude whether there might be other reasons for the dementia. Often we'll look at your other prescriptions and medications, which can also sometimes create symptoms. They might look at depression, which can also mimic dementia. So there are exclusions that are done. And then one would hope that you could also get access to a brain imaging, either an MRI or a CT, again to get a baseline assessment. But the cognitive test is the primary mechanism that is used currently. Yes.
Let us know a little bit about the Brainwell Institute.
Sure. So the Brainwell Institute is a think tank that's focused on dementia. But I like to joke we do more than just the thinking. We really try to take that evidence and research and help move it into practice. And one of the main purposes of the Brainwell Institute, it was established to support care coordination for dementia across the country. So that recognizes that, in fact, in Canada, we have 13 health systems because every province has its own infrastructure and health system. And so we want to work and do work with local partners and champions to collaborate and to build a sort of eventual infrastructure that would support dementia care coordination. And once that's done, the Brainwell Institute will wind down. We have a 7-year mandate to do that, and it's been established only for that purpose.